Good morning, everyone. So today we'll be presenting a CGR from the Department of Diagnostic and Interventional Radiology, and the topic that we chose was portal hypertension, imaging and interventions. How radiology helps in cases of portal hypertension in the diagnosis as well as management. So let's first look at the definition of the portal hypertension. So anywhere in the body, when we define hypertension, it is either due to an increase in the vascular resistance or increase in the overall blood flow. The same applies here, or both, resulting in hepatic venous pressure gradient of more than 5 mm mercury. So the normal hepatic venous pressure gradient is less than 5 mm of mercury. When does it become clinically significant portal hypertension? When the hepatic venous pressure gradient increases to more than 10 mm of mercury. What are the complications that can happen in cases of clinically significant portal hypertension? Ascites, portosystemic collateral development, because the body tries to auto-regulate and decrease the hypertension by either the pre-existing collaterals or the new development of portosystemic collaterals. You can have variceal bleed, which is a significant morbidity associated with portal hypertension, and the risk of hepatocellular carcinoma. When the HVPG is more than 12 mm of mercury, there is high risk of variceal bleed, so we need to treat all those cases. Now let's look at what are the causes of portal hypertension. So as we discussed, you can divide the portal hypertension into prehepatic causes, intrahepatic causes, and the posthepatic causes. So the prehepatic causes, the most common ones are non-cirrhotic portal hypertension, otherwise extrahepatic portal vein obstruction or non-cirrhotic portal fibrosis, which usually happens after portal vein or splenic vein thrombosis. So splenic vein thrombosis causes left-sided portal hypertension or sinistral hypertension. Most common cause of intrahepatic portal hypertension is cirrhosis, and then few other cases like metabolic diseases which are less common. Posthepatic, usually either the IVC obstruction or the outflow obstruction of the liver in the form of obstruction of hepatic veins, or cardiac causes which can lead to portal hypertension are posthepatic causes. So what are the complications? Why should we know about portal hypertension and why should we manage it? Because if we don't treat it, what will happen? The most important complication is varices. So they can be esophageal varices, gastric varices, or including both esophageal and gastric varices. And the other complications that can happen with cirrhosis and portal hypertension is ascites, hepatorenal syndrome, which can happen, spontaneous bacterial peritonitis if infection happens, and then hepatopulmonary syndrome or portopulmonary syndrome, which are pulmonary complications of portal hypertension. Cardiac complication is cirrhotic cardiomyopathy, and if a lot of ammonia goes directly into the brain, the patient can develop hepatic encephalopathy. So what are the imaging signs of portal hypertension? We can divide them into direct signs and indirect signs. So in direct signs, you see dilated splenoportal axis and reduced portal flow. So the portal velocity, normal velocity is 12 to 18 centimeters per second. When it is reduced less than 12 centimeters, with either, so first the portal flow will decrease, then it will become stagnant, and ultimately it will get reversed. And the presence of collateral. So these are direct signs. Indirect signs that we most commonly see are in the form of splenomegaly and ascites. So we have to understand that portal hypertension is not synonymous to cirrhosis. Even in the absence of cirrhosis, you can have portal hypertension like in prehepatic and the posthepatic causes. So let's look at this case. This is a 29-year-old female who had complaints of dysphagia, lethargy, and some weight loss. She underwent and she saw a physician outside, and he advised an ultrasound abdomen, which was done outside, and it showed splenomegaly, and the liver echo texture was normal, and she was advised a non-contrast and a contrast-enhanced CT. So what do we see in the non-contrast images here? So you see there is the esophageal wall thickening, and there are some abnormalities in the right lower lobe as indicated by the arrow. The esophageal thickening is extending into the gastroesophageal junction also. So here you can see there is bulky thickening in the lower end of esophagus as well as the gastroesophageal junction. And on the lung window you see some bronchiectatic changes, probably due to previous infection, which is resolving now, you can see on this. In the CECT abdomen that was acquired outside, you can see the mass is not enhancing, which was seen on the non-contrast. The same images, same morphology is seen here. And on the contrast, what do you see? You see an extra vessel which is arising from the abdominal aorta and is supplying the right lower lobe mass. You can see on the VRT images, there is an abnormal vessel which is arising from the abdominal aorta above the celiac trunk, and then it is supplying the right lower lobe. And these are the probably the sequelae of previous infection. So what happens whenever abnormal supply, systemic supply is there to a lobe of lung, what is the diagnosis? So the diagnosis, the scan was read as an esophageal mass with right lower lobe sequestration. The patient was referred for the esophageal mass biopsy to the AIIMS Jodhpur. He presented in the emergency and then the scan came to us for review. So we looked at the scan and something, we didn't actually agree with all the findings. So this diagnosis of the lower lobe sequestration is absolutely right. But the esophageal mass looked slightly different. It is not enhancing at all. So we called the patient for an ultrasound, and on ultrasound we found something which was not consistent with this diagnosis. So we did a repeat CT to prove our findings. So on the repeat CT, you can see on the portal venous phase contrast enhanced CT, these are actually all bulky and large collaterals which are mimicking an esophageal mass. Previously, even though contrast enhanced CT was done, but the protocol was not right. It was not a venous phase, it was an arterial phase. So not even a single one of the collaterals was enhancing. So it was mimicking like a mass, which in practicality, as you can see in the sagittal images, all the possible columns of esophageal varices that you can see in a case, all 4 or 5 columns are seen in this case. And the right lower lobe sequestration, that diagnosis was correct. So the patient was referred for an esophageal mass biopsy, which was not done later, and she was treated for these esophageal varices. So here you can see the same case, multiple gastric as well as the esophageal varices. And when we look at the liver, what do we see? There is enlargement of the portal vein, particularly the central part of the portal vein, but the peripheral pruning of portal vessels is there. So this is quite typical of non-cirrhotic portal fibrosis. The liver is slightly smaller in size, and you can see the left coronary vein is significantly dilated, leading to all this gastroesophageal collaterals. So the final diagnosis was non-cirrhotic portal fibrosis with giant esophageal varices mimicking an esophageal mass. So what is the learning point from this case? We have to always try to get a correct protocol, because the probability of a correct diagnosis increases with the correct protocol. So now let's look at the portosystemic collaterals that can develop in portal hypertension. The most common one that develops are the varices, and then you have the recanalization of the paraumbilical vein. Varices, you can have esophageal as well as gastric. You can have colonic varices, paraduodenal varices, rectal varices, mesenteric varices, and we'll see one by one all of them. So here, this is a patient of extrahepatic portal venous obstruction. You can see that the splenic superior mesenteric vein is not seen, and you can see a large inferior mesenteric vein collateral, which is then further leading to rectal varices, as seen on the sagittal as well as the coronal VRT images, and you can see abnormal enhancement of the rectal varices. So sometimes CLD patients can bleed from rectal varices, so it is important to identify them. In this image, another case of EHPVO. Here you can see so this is the second part of the duodenum. You can see abnormal vessels within the wall of the duodenum. So on all the 3 planes, axial, coronal and sagittal, you can see duodenal varices within the wall of the duodenum. So these are ectopic duodenal varices. What are the other locations of ectopic varices that you can have? So you look at this image and this image. This is one case. So you see jejunal walls with abnormal tangle of vessels. No other loop shows this kind of abnormality in the form of enlarged vascular channels. So these are jejunal varices. In this case, what do you see? You see the pylorus of the stomach, which shows this abnormal tangle of vessels. So this is a case of pyloric varices. So these are all ectopic varices. These are less common, but they are more prone to bleed and difficult to manage. So their recognition is very important in case of GI bleed. This is another case where this is a transverse colon. You can see abnormal tangle of vessels in the transverse colon as well as in the stomach. So you can have multiple locations of varices in the same patient. So these are colonic varices. What are the other shunts that we can see? So typically the most common one that we see is, along with splenomegaly, is a gastrolino-renal shunt. So lino means spleen. So pathophysiologically, this shunt comprises of some gastric component with gastric varices, some splenic vein drainage into the left renal vein. So it is a portosystemic shunt. Sometimes you can have only gastrorenal component with very little of splenic component, or sometimes you can have only lino-renal shunt with absence of gastric component. On the sagittal images also, you can see the gastrolino-renal shunt draining into the superior surface of the left renal vein. So the patency of the left renal vein is very important, because if we are going to treat this by any other means other than either by the endovascular means or by surgery, we need to know the status of the left renal vein. for the better approach and for making a shunt. This is an example of retroperitoneal collaterals, which are more commonly seen in cases of bud carry. So another important thing that we commonly see is EHPVO. So here you can see even the intrahepatic branches of portal vein has thrombosed and are replaced by collaterals. So you can have a combination of prehepatic and intrahepatic portal hypertension as well. And this is encircling the biliary radicals and compressing the common bile duct, as you can see in this case. Extensive, innumerable number of small low flow collaterals replacing the entire main portal vein, even the branches of the right and the left portal vein, and cranial part of superior mesenteric vein and the confluence side of the splenic vein. So all these are replaced by a bunch of collaterals, leading to compression of the main compression of the CBD and biliary dilatation. This biliary dilatation can be better visualized on MRI, but sometimes it's so marked that it can even be seen on CT. So these are CT MINIP images only, which tell you that this is a case of EHPVO with portal biliopathy. And you can see a lot of pericholecystic collaterals as well. This is another case. So sometimes the last case I showed you that there was a shunt draining into the superior surface of the left renal vein. Here we see a shunt which is going from the mesentery. So this is the inferior, this is the superior mesenteric vein, lower part. There are mesenteric collaterals which is draining into the inferior surface of the left renal vein. So this is a mesenterico-renal shunt or mesorenal shunt. Usually it may or might not go through the gonadal vein. So here this is an example of a mesorenal shunt. What else do we want to know when these patients are being planned for surgery? So because they will have huge splenomegaly, so you can see marked splenomegaly almost reaching till the left iliac fossa, and all these starry sky calcifications are gamma antibodies. We also want to know how many splenic aneurysms are there. So these are all true aneurysms. We want to know whether the surgeon will be able to get a stump for ligation of the splenic artery and what is the length of the remaining stump. So you can see multiple hilar as well as intrasplenic aneurysms and multiple collaterals. All these patients, they will have sometimes, lot of times pancytopenia with infection, so they will have a lot of perisplenitis also. The surgery becomes difficult when there is a lot of perisplenitis and chances of complications increase. So we want to do the whole collateral mapping, which side the maximum collaterals are there and which side we have to be really careful. So this is another case. Here the patient has NCPF and she is being planned for splenectomy. So you see there is a whole lot of periumbilical varices. So in the era of minimally invasive surgery, when we put ports in laparoscopy or robotic surgeries, we want to be we should be aware of these periumbilical collaterals, because if we are not aware of these collaterals and we put a port leading across the collaterals, it can lead to catastrophic bleeding. So we have to do umbilical collateral mapping before port placements. Sometimes, depending upon the subcutaneous thickness, they might not be clinically visible always. So the post-hepatic cause, the most important cause that we see is Budd-Chiari syndrome. So it results from partial or complete hepatic venous outflow obstruction in the hepatic veins or vena cava up to the cavo-atrial junction. So you need at least 2 hepatic veins to be closed. Most of the times all the 3 hepatic veins are closed by the time patient is diagnosed and reaches the hospital. So Budd-Chiari syndrome can be primary or secondary. So why is it important to differentiate? Because then based on that we are going to treat. What is secondary Budd-Chiari? Suppose if there is a renal tumor, like Wilms tumor has a tendency to go into the IVC and go up to the cavo-atrial junction. So that picture will be secondary Budd-Chiari. In that case, you have to treat the primary etiology and not the liver itself. Primary Budd-Chiari is the one that we treat a lot of times endovascularly. And depending upon the chronology of symptoms, also it can be divided into acute, subacute, and chronic. So here we see what are the manifestations of acute Budd-Chiari. You see acute thrombosis of all the hepatic veins. You can visualize all the hepatic veins separately, and they are slightly prominent with hypodense thrombus within. You will see hepatomegaly, you will see a lot of ascites, and this is the enlarged caudate lobe. So the caudate lobe has a separate vein. As you can see here, the caudate lobe is draining separately into the IVC. So this vein is not affected by the thrombosis of all the 3 superior veins. So this vein is patent, and so the caudate lobe hypertrophies to a great extent. Over the time, these hepatic veins will change into echogenic fibrous cords. And what do we assess on the Doppler? There may be a loss of phasic variation, absent flow, reversed flow. So for that, we have to know what is the normal flow in a hepatic vein. So this is how a normal triphasic flow looks like in a hepatic vein. It's hepatofugal, and you can see in the systole as well as diastole. This is the triphasic flow. What happens when there is an abnormality or obstruction in case of bud carry? You can see this converts into a monophasic, low, not undulating waveform. Like this is called as pseudo portal flow. So normally the portal flow slightly looks like that, but with more respiratory and phasic variations. So this is called as pseudo portal flow. Now we know after the Doppler that there is something wrong with the hepatic veins or the IVC. A lot of times patient presents with subacute phase. So here what do we see in the imaging? Because the central part of the liver is supplied by the portal vein, so in the portal phases, the peripheral density will be decreased, enhancement will be less, and the central enhancement will be more, because inflow is maintained, only the outflow is obstructed, right? So inflow is maintained, so centrally in the portal phase you will have hyper enhancement, but in the delayed phases, because of the presence of multiple hepatic veno-venous collaterals, what happens? There is progressive increase in the peripheral liver parenchyma. So in the delayed phase, the peripheral enhancement is increased with some slight relative washout. So this is typically called as the flip-flop pattern of enhancement in bud carry. Okay. Now let's come to the chronic bud carry. So a lot of patients also come to us in chronic stage, where what do we see? You see cord-like caliber of hepatic veins. So in this case, I'll show you with an example. So this is the right inferior accessory hepatic vein, which is completely thrombosed. You cannot make out a lumen at all. So this becomes cord-like. So this is chronic thrombosis. And superiorly, what has happened? All the three hepatic veins, you can see some lumen in that, but they do not reach till the IVC confluence, and there is also obstruction at the level of the IVC confluence of all the three hepatic veins. So practically almost all four hepatic veins are thrombosed, and you can see ascites also in these images, and in addition you can see multiple collaterals with enlarged liver and heterogeneous ecotexture of the liver parenchyma, which is suggestive of bud carry syndrome. Another case, this was a 35-year-old male who complained of abdominal distension and dull aching pain from last 8 months. He had 3 episodes of melena before admission. There was no history of hematemesis. Baseline abdominal girth was 76 centimeters, and a screening ultrasound abdomen was performed with the clinical diagnosis of bud carry syndrome. So what do we see on the ultrasound and Doppler? You see the right hepatic vein, which is, you can see the lumen of the right hepatic vein, but there is a small here echogenicity within the lumen, and it is not joining to the IVC confluence directly. So you can see this is a small length of stenosis and occlusion of the right hepatic vein. Rest of the hepatic veins we don't see at all, and in addition we see multiple hepatic veno-venous collaterals. So this is the caudate vein coming and draining into the IVC. So you don't see any hepatic veins which are directly draining into the IVC, but you see right hepatic vein which has short segment stenosis or occlusion, and we'll see how this case was treated in radiology. Another case, 11-year-old boy with abdominal distension and vomiting for 1 week. Ultrasound showed moderate ascites, as you can see on the ultrasound images, with liver parenchymal changes. He was initially managed with conservative management for about a month with no significant improvement, and he was referred for further management here. So here on the ultrasound, you can see hepatomegaly with ascites, and you can see multiple comma-shaped collaterals with thrombosis or occlusion at the level of multiple hepatic veins at the IVC hepatic confluence, and these collaterals are veno-venous collaterals, and from the clinical image you can see gross ascites with distended abdomen and multiple collateral veins along the anterior abdominal wall, which are trying to drain. And on the imaging, what do we see? Heterogeneous parenchymal enhancement in the venous phase. We don't see actually any hepatic veins which are directly draining into the IVC. We see some prominent azygous system and hepatomegaly, as you can see, but the IVC was patent here, you can see here. So this is a case of subacute bud carry syndrome, and we'll see how this patient can be managed. Another case, 27-year-old male complained of having mild respiratory distress from last 8 to 9 years. He was also having minimal abdominal distension, but was not pursuing it a lot. In the recent past 2 to 3 months, he had increased respiratory distress, and on evaluation, he was found to have IVC complete occlusion with CLD changes. For the preceding 1 month, he was on anticoagulation, and it was not helping much. So here on the ultrasound images, here you can see this is the infrahepatic and intrahepatic IVC, which is dilated, and the dome shape of the IVC where it gets occluded, and a short segment occlusion of the intrahepatic IVC in this location. This is called as the minaret sign of IVC occlusion because of its shape looking like a minaret, dome shaped of IVC occlusion, and you can see significant ascites On CT, what do we find? We see changes of chronic liver parenchymal disease. We can see right inferior hepatic vein, which is patent, but IVC is completely occluded. So, as we discussed that Budd-Chiari can develop by either hepatic venous obstruction or by IVC obstruction. So, the changes that happen in liver are similar, and as this is a short segment occlusion, this can be treated. Another case, 45-year-old male. So all these patients of Budd-Chiari, they are at high risk of developing hepatocellular carcinoma also. So this patient was treated for Budd-Chiari syndrome, and during the follow-up, you can see there is a nodule in the left lobe of liver which was picked up on ultrasound. And for better characterization, multiphasic CT was done. So on the non-contrast, it is almost iso to hypodense. It shows arterial phase enhancement and then becomes progressively shows progressively increased enhancement in the portal venous phase, and the delayed it shows equivocal washout. So we are not very sure whether it shows washout or not, but because the background liver parenchyma itself is very heterogeneous, and you can see the multiple paravertebral collaterals and the enlarged azygous vein, and the right inferior hepatic vein is patent with lot of ascites. So to characterize this lesion, so the differentials at this point was, is it a regenerative nodule or is it an HCC? So we did a contrast enhanced MRI with hepatocyte specific contrast media, which is quite specific to diagnose or rule out HCC. So you can see multiple collaterals due to the occlusion of the hepatic veins and the IVC confluence, intrahepatic veno-venous collateral. You can see the nodule here, which does not show significant diffusion restriction. The nodule is slightly hyperintense on T1 and is almost iso-intense on T2 weighted images. Non-contrast T1 itself, it is hyperintense and it does not show significant enhancement on the subtracted venous phase images. In the further venous phase images, it shows progressive enhancement, and delayed also it shows progressive enhancement. In hepatobiliary, it retains the contrast. That means it has normal hepatocytes within it, and it is a benign nodule and not HCC. So the diagnosis of benign regenerative nodule is confirmed, and he is being followed up for the same. So now coming up to the last case, this is a 10-year-old female who presented with cyanosis since 4 months of age. She also had failure to thrive, and the respiratory distress had increased since last 3 months. She had an echo and was referred to the Department of Radiology to rule out a pulmonary AVM, because on contrast echo, there was complete opacification of the left atrium and left ventricle, left cardiac chambers after 3 cardiac cycles, and CTPA was advised. So when we looked at when we saw the case, you can see that there is a deep cyanosis involving the lips and the tongue, and lot of clubbing involving both the upper limb as well as the lower limb. So, and on the room air, her saturation was significantly less than the 90%. So we decided to do a CTPA protocol. Along with that, before itself, we had done an ultrasound abdomen which showed abnormal liver ecotexture and parenchyma. So we decided to do the same CT in the same contrast bolus, both evaluating both the chest, pulmonary vasculature as well as the liver, so that we don't have to do the CT again, decreasing the contrast volume also. So here you can see on the CT pulmonary angiography, the right side of lung looks relatively normal, but on the left side you see all these abnormal vessels. So these are all dilated pulmonary veins which are going up to the almost the pleura, and you see multiple small abnormally increased number of vessels on the left side predominantly, not on the right side but left side predominantly. So here you can see if you compare the right side pulmonary vessels, the width of the pulmonary vessels on the right side is less, but on the left side it is significantly more. So when you look at the mediastinal window, as you can see here, there is paucity of vessels on this side with a significant increased vessels on this side. Pulmonary artery is enlarged, including both the right and the left pulmonary artery. The left sided chambers are enlarged, both left ventricle and left atrium, and the pulmonary veins are also dilated. So she is suffering from pulmonary hypertension with pulmonary vasodilatation. So on the VRT image also you can see all these vessels on the right side, they kind of look less broad in size as compared to on the left side. So left-sided pulmonary veins and vessels are very prominent. So now when we come to the CT abdomen, here you can see in the arterial phase, the liver did not show significant abnormality, but on the venous phase, you can see it is quite heterogeneous. It shows multiple arterial enhancing nodules as well as hypodense areas, which are not showing any washout. And you can also see changes of other portal hypertension like gastric varices and esophageal varices, prominent azygous system. So she has all the features of portal hypertension, clinically significant portal hypertension. She underwent an endoscopy which confirmed the varices. So now when you have all this triad of CLD with portal hypertension and intrapulmonary vascular dilatations, the diagnosis becomes hepatopulmonary syndrome. So this is all from my side. Now I would request Dr. Pawan to tell you how the management of portal hypertension takes place in a multidisciplinary approach and how radiology plays a very important role.
Good morning all. Thank you Dr. Taruna for extensive discussion about the diagnostic aspect of the portal hypertension. So my job is to describe the interventional aspect of the portal hypertension, how we will manage the various complications or the manifestations of the portal hypertension. So as we all know, the various options of the treatment for portal hypertension include medical management. So all portal hypertension patients first start with the medical management. Then there is an endoscopic approach in terms of like variceal management, variceal bending, ligation or the glue injection. Then comes the role of endovascular intervention. So we have a variety of cases which I will be showing in the subsequent slides. And the last but not the least surgical option including the transplant and the various shunt formation. So I will not be discussing the diagnostic part. I will directly going into the interventional part. So when we talk about the management of the portal hypertension, our primary goal is to reduce the portal pressure. And if we are not able to achieve the reduction in portal hypertension, then we'll try to palliate or control the symptom which is arising because of the portal hypertension. So there are many options of the reduction of portal pressure, including if there is any hepatic venous outflow obstruction or IVC obstruction, we can recognize. There is a technique which is called as a transjugular intrahepatic portosystemic shunt, which I will be discussing in subsequent slides. Then if there is any occlusion of the portal vein or its tributary, we can go and recanalize those vessels. Then if there is a formation of arterioportal fistula which can subsequently lead to portal hypertension, we can embolize and do prophylactic, we can prevent the future development of portal hypertension. Then sometime we can go and do splenic artery embolization just to prevent the inflow, and that will again help in the reduction of the portal pressure. And if there is any shunt which is already created, then if sometime it undergo stenosis or occlusion, we can go and try to open that shunt. And if all these options are not possible, then we can do symptom relief, the treatment in which we can do directly the treatment of the symptoms. Like one technique is the balloon occluded retrograde transvenous obliteration of gastric varices, which I will be discussing in subsequent slides. Percutaneous variceal embolization not being done nowadays, and percutaneous peritovenous shunt, again it is not being done routinely. So these are the list of my procedure or the cases which I will be showing in the subsequent slides. So as we all discuss about the portal hypertension, but first thing comes how we will measure the portal pressures. So there are technique, one technique is the direct measurement. You can directly puncture the enter into portal system and then you can measure the pressure, but that is not possible in all the patients. So what we'll do, we will measure the indirect pressure. How we will measure indirect pressure? We first enter through internal jugular vein into the hepatic vein. Preferably right hepatic vein, we will measure the free pressure without obliterating the lumen. So that is the free hepatic venous pressure. Then we inflate the balloon within the hepatic vein and we measure the wedged hepatic venous pressure. And the difference of the pressure gradient between both these wedged versus wedged and free, it is called as hepatic venous pressure gradient. So which is discussed in the previous slide also. So it has a very important correlation with the portal perfusion pressure. So in normal patient, it is usually less than 5 or equal to 5, and sometime even in the non-cirrhotic portal hypertension, again we can get HVPG less than or equal to 5. And if with gradual increase in HVPG, we may see various manifestations of portal hypertension. We call portal hypertension if HVPG is more than 5. If it is more than 10, then patient will have a decompensation in form of ascites. At more than 12 mmHg, patient has a variceal bleeding, and at more than 16 mmHg, there is a risk of rebleeding. And if it is more than 20, there is a high risk of mortality. So coming, I am showing a case in which we have entered into the right hepatic vein. This is the how our catheter is in the right hepatic vein. We have measured first free hepatic wedge pressure, then we have a wedge into one of the small branch, and we have measured the wedged hepatic venous pressure, and the difference between both pressure is we measured, and that is HVPG. The other technique in which we have entered into hepatic vein, we have taken the first free pressure and then we have inflated a balloon within the hepatic vein to obliterate the flow, and we have measured the wedged hepatic venous pressure. So by using either of one technique, we can measure the HVPG, and that is helpful in the management and the prognostication of the patient. Coming to the procedure, so this is a transjugular intrahepatic portosystemic shunt in which what we will do, we will divert a portal venous flow across the liver parenchyma into the hepatic vein. So we will make an artificial channel between in the liver parenchyma, and that will divert the blood from the portal venous system into the systemic circulation. The role of this is to reduce the portal venous pressure, and subsequently the manifestation which is developed because of portal hypertension will be relieved by doing this procedure. So I will be discussing with this case example. So this is a 35-year-old male patient who has a known chronic CLD because of alcoholic liver disease and presented with the hematemesis and melena. This patient presented last week only. He had a significant amount of hematemesis and melena, and at the time of presentation in emergency, the patient is having tachycardia, hypotension, and this is the patient has a severe similar episode 20 days back. So for which they have done endoscopic band ligation. But this time when they have entered, they have seen there are at least three post-EVL ulcer, and one of these ulcer is having active spots. So in view of the patient condition and the active spot, they have put this tamponade stent called as a Denis-Ella stent, in which this is just a prophylactic stent to prevent further bleeding, because it will give a tamponade and it will stop the varicose bleeding temporarily. But after that, we have to do something to permanently relieve this issue or the varicose bleeding. So what we did contrast enhanced CT, and what we can see, this is the stent which was placed endoscopically, and what we see in this case, there is a lot of blood within the stomach lumen, and patient is having poor hemodynamic status. So we have decided to go with the TIPS procedure. We have taken the patient in emergency. This is the first run which showing hepatic venous opacification. Then through liver parenchyma, we have entered into the portal vein. So this is the most critical step, because we don't know where is the portal vein. So by using different fluoroscopic and the ultrasound guidance, we have tried to puncture the portal vein through the hepatic vein. And this is the final tract. We have entered from hepatic vein across the liver parenchyma into the portal vein. This is the angiogram we have taken from the superior mesenteric vein. Surprisingly, what we usually see, the flow in this vein is towards the liver, but in this case, the entire blood is diverted away from the liver into the collaterals. That's why the patient is having significant bleeding because of the varices. So we have done the tract dilatation using balloon. Then subsequently, we have placed the stent within the hepatic parenchyma. And this is the culprit variceal source. This is coronary vein which is having supply of this varices which is going till the esophagus, and this is the source of bleeding. So we have embolized that variceal source also by using coiling. And this is the final follow-up venogram, in which we did injection from the portal vein side. This is across the liver parenchyma into the hepatic vein. So most of the blood which is coming from the portal circulation is diverted away from the liver into the systemic circulation. So patient is tolerated this procedure very well. Noradrenaline is stopped. Patient is extubated, and no further episode of hematemesis. This stent was removed after 1 week and discharged the patient in stable condition. Coming to the aim of the variceal bleeding management, the aim is to reduce the HVPG less than 12, or at least 50 to 60% reduction from the baseline. And after putting this TIPS stent, we have to follow the patient using a Doppler ultrasound every 3 months, and thereafter every 6 months, to look for any new development of stenosis or occlusion of stent. If any occlusion of stent is there, we have to revise, do venogram, and we have to revise do angioplasty. So apart from the variceal bleeding, we have also various indications like refractory ascites, refractory hydrothorax, hepatorenal syndrome, Budd-Chiari syndrome. These are the all indication for the doing TIPS, and also to bridge the liver transplant patient if patient is having cirrhosis with all features of decompensation. So there are some contraindications for doing TIPS. So detailed evaluation of patient is important, including pulmonary hypertension, cardiac failure, liver failure, any present sepsis or biliary obstruction. These all are the contraindications for doing TIPS. Coming to the next procedure, that is the balloon occluded retrograde transvenous obliteration. This is the procedure in which we are not directly reducing the portal pressure, but what we are doing, we are directly entering into the varices, and we are just obliterating those varices without reducing the portal pressure. So this is indicated only in cases of bleeding gastric varices, not in the esophageal varices. And second indication is if there is a patient who presented with hepatic encephalopathy because of large shunting of blood from the portal to systemic side. So these are the only two indications. If patient has a esophageal varices along with the gastric varices, then this is one of the contraindications to perform this BRTO. What we do, we usually enter from the either femoral vein or from above interjugular vein, and we enter into renal vein, and we try to cannulate the gastrorenal shunt, which usually opens during whenever there is a gastric varices, this shunt is opens, and we enter this, occlude it with balloon, and we inject directly over embolizing agent to obliterate those varices. So coming to the case, a 45-year-old male who has a alcoholic CLD presented again to emergency with hematemesis and melena, and the patient has a typically isolated gastric varices with no esophageal varices. So we did the CT in which we have seen there is a multiple varices which is projecting within the stomach lumen, and this is the source of bleeding. And what we see, this is the gastrorenal shunt which is patent. So what we have done, we have entered through the femoral vein into the gastrodenal shunt. We have obliterated, inflated our balloon, and through this balloon at the central lumen, we have injected the sclerosant, which is directly going into the varices. And this is the follow-up CT after 6 hours. We have kept our balloon for at least 6 hours to obliterate all those varices. And this patient did very well. And this is the follow-up CT after 2 weeks. These are the varices which is seen in the baseline, and this is the obliterated varices after 2 weeks, which is previously seen in this image also. And all those varices are obliterated, and patient has no repeated episode of hematemesis till the 1 year follow-up. Coming to the companion case, this is a 62-year-old male who has presented with significant hematemesis and requiring multiple blood transfusion. This patient has a large gastric varices. We can see there is a spurt from the one of the varices. This patient was presented to outside hospital, and they have referred to us for further management of the BRTO. So we did the CT in which we can see multiple bulky gastric varices with no esophageal varices. Again, we went ahead. This time we entered through the internal jugular vein directly into renal vein and into gastrodenal shunt. We have put here a vascular plug. Vascular plug is a device which is kept there to obliterate the gastrodenal shunt, and we have injected the embolizing agent to obliterate the gastric varices. Again, the follow-up patient after 2 weeks, we can see there is all thrombosed varices with this is the vascular plug which is kept there in the gastrodenal shunt. So coming to the next entity, that is Budd-Chiari syndrome. Already we have discussed about the what is the diagnostic manifestation of Budd-Chiari syndrome. So there are multiple options of medical, starting from the medical management, then the workup for the differentiate between primary and secondary causes, and these are the options we have: hepatic vein angioplasty, IVC angioplasty, or DIPS procedure. So coming to the case, this case has already been shown. In this case, there is a short segment occlusion of the right hepatic vein with multiple collateral, and this is an elastography image. This is very helpful image whenever we do ultrasound for the especially Budd-Chiari syndrome. We can see there is a congestion which is shown by the red color and the yellow color, and we can see there is short segment occlusion. So this is a CT which is typically showing flip-flop pattern with the presence of varices with patent IVC. So we went ahead and we have entered using our different catheter wire combination. We have cannulated the right hepatic vein, and these are the multiple collateral which is seen after entering into right hepatic vein. We have done balloon angioplasty and followed by the stent placement, and this is the follow-up angiogram after putting a stent. So very good antegrade flow has been re-established, and patient has relieved in the symptoms. And this is the follow-up ultrasound. We can see previously this hepatic vein is not filling with the Doppler flow. Now it is started filling. The elastography image, previously it is showing red and yellow color, which is showing of increased congestion, and now it is relieved and it is showing blue color of normal liver stiffness. Another similar case which is already shown, a case of IVC occlusion with a large complete short segment cutoff of the upper end of IVC with ascites. So this is the CT in which we can see there is a occlusion of the short segment of inferior vena cava. We have entered, and when we take a run, there is a complete occlusion. No integrate flow of IVC into the heart is seen. So we have crossed and we have done the balloon angioplasty, and this is the final angiogram we after the doing balloon angioplasty. So this is a baseline image with a complete occlusion, and this is the image after opening. We can see very good flow across the stenosis. This is again a different case profile. Young boy who is presented with abdominal distension, ascites, already shown the case, coarse liver ecotexture, multiple collaterals, venovenal collateral ascites, and all occluded hepatic veins and gross distension. So what we did, first did the CT to again see whether there is IVC is patent or not, what is the status of other hepatic veins. So no hepatic vein was patent, on IVC is patent in this case. So we went ahead and first tried hepatic vein access because that is more physiological. So we have tried both interjugular approach as well as percutaneous direct hepatic vein approach, but we could not succeed to recanalize the hepatic vein. So by in next step we did the direct this intrahepatic portosystemic shunting. We entered through IVC, directly puncture the portal vein. We have created a shunt channel within the liver parenchyma. We have put this stent, and so now the portal venous flow is diverted through this shunt into the systemic circulation. This lead to significant reduction in the portal pressure. The kid has responded very well with significant reduction in the abdominal distension. We have followed this patient at least for, we are following this patient for last 3 years and having very good response to this procedure. In one time patient has a stenosis of this stent which we have revised by doing angioplasty. Coming to the last case, this is a 10-year-old child who was presented with blood trauma abdomen. The first was positive, so CT was done. We showed a grade 3 liver injury. So we can see there is a hematoma within the liver. Along with this, there is some area of the liver which is showing early enhancement. And surprisingly, we see there is an early enhancement of portal vein in the arterial phase. So we have suspected some traumatic communication between the hepatic artery and the portal vein. So we have suspected traumatic arterial portal fistula. So we went ahead, we have taken the right hepatic artery angiogram, which we showed there is a opacification of the portal vein. So basically, if we left this patient untreated, there is a gradual increase in the pressure of the portal vein, and which can lead to future development of the portal hypertension. So we went ahead and we have did the coil embolization, and then subsequently there is no opacification of the portal radical in the hepatic artery angiogram. So we have followed this patient from following this patient from last 1 year. Patient is doing well. This is the resolving hematoma. There is no good flow within the portal vein, no arterial flow within the portal vein. So all these cases are not straightforward. We encounter many complications which may be intraprocedural, which may be periprocedural or the delayed. So capsular puncture of the liver and hemoperitoneum is one of the dreaded complications which may sometime life-threatening also. Biliary puncture of the periportal sheath or the hematoma is again a complication. Stent occlusion during the deployment is the one of the intraprocedural complication. There is a lot of periprocedural complications starting from hepatic encephalopathy to stent occlusion, hemophilia, portal venous thrombosis. Sometimes stent may be misplaced or migrated, infection, renal failure, hemolysis. And delayed complication may be recurrence of the ascites or vessel bleeding or shunt stenosis. So few of the complications which we encountered in our cases. One of the case in which we have tried, we are doing a direct intrahepatic portosystemic shunt, and during our attempt to cannulate the portal vein, we have punctured the liver capsule, and you can see there is extravasation of the contrast within the peritoneum through the liver capsule. So we finished our case quickly so as to reduce the congestion of the liver, and this bleeding has stopped with time. Then there is another complication which we have, rather than puncturing the portal vein, we have punctured the periportal. You can see periportal soft tissue, and which lead to periportal hematoma. Again, it is a self-limiting condition which has resolved with time. Then sometime we may inadvertently puncture the biliary radicals, and this is the opacification of the biliary radicals instead of portal vein. And this is one of the case in which we are attempting the BRTO procedure. We have punctured the varices, and there is a development of the retroperitoneal hematoma. So it is very important to diagnose these complications early, so that we can do preventive measure, or we can manage these complications on time. So coming to the aesthetics of the department, so we have started our vascular radiology program, interventional radiology program, since installation of our DSA machine in the end of 2015. So gradually we have seen there is a increase in the number of the vascular procedure in the last many years. These procedures are vascular procedure which was done on the DSA room, excluding all the biopsy and drainage and the non-vascular procedures. So gradually we have seen there is a significant increase in the number of vascular procedures. Coming to the aesthetics of the procedure which we did for portal hypertension related procedures. So we did all variety of the procedure, including starting from the HVPG measurement to the hepatic vein angioplasty, IVC angioplasty, tips and dips, BRTO procedure, embolization of the arterioportal fistula, splenic artery embolization, and revision of the occluded shunt. So totally we have performed the 147 patients, out of which this 23 are the diagnostic procedure to measure the HVPG. Rest of all are the therapeutic procedure. And this is our result. We have done 124 therapeutic procedure, out of which the technical success was almost 88 to 90%, in which few cases we have succeeded in second or third attempt, because it depends upon the anatomy. So after changing the hardware, we have succeeded in 3-4 patients in the second or third attempt. We have encountered minor complication in almost 14-15% of cases, and we have 3 major complications in terms of mortality, in which 1 patient is of BRTO and 2 patients of TIPS. So to conclude, imaging, as we already seen during the diagnostic part, that ultrasound Doppler and correctly perform the multiphase CT is the mainstay for the diagnosis as well as planning of the treatment for portal hypertension. We have seen that interventional radiology procedure has an important role in elective as well as emergency management of the portal hypertension by doing various procedures. And one most important part is the careful selection of patient, because sometimes we are going with the intent to treat, but we may harm if our patient selection is not correct. So I would like to thanks different departments of the institute who is a part of a team in the management of these procedures, starting from the Department of Gastroenterology, Surgical Gastroenterology, and most importantly anesthesia and critical care, who has been providing support during procedure as well as during the post-operative management, the emergency medicine, general medicine team, pediatrics, and the pediatric surgery department. And I will also like to thanks our HOD sir, Pushpendra Kheda sir, and our DSA team and the fellow in the preparation and the management of all these patients. Thank you very much. If there is any query or question, we will be happy to answer.
Excellent presentation, and I know that your team is doing the wonderful job, and I know that physician have the sometime develop the handicaps. As you rightly told, first the medical management, but they work up to the certain extent. After that, definitely we feel ourselves handicapped, but with the IR peoples around, definitely we can benefit the patients. The surgeons have become now the last entity, which they will not like it, as you told. They are always there to help you and us. Wonderful presentation. Thank you.
Thank you, sir.
I'll just take a minute to thank all the departments, because doing a procedure is easy, but the pre and the post-op care is more important, especially with patients who have portal hypertension. So the post-op care is especially important. And word about surgery is that the role of surgery has come down, because as it is, these patients are morbid. So to open up a patient with ascites and do anything is always going to be difficult. Though we always, give a call to our surgical colleagues that we are doing this case and we may end up rupturing major vessels. But thankfully, that has not happened till now. Thank you so much.